consequences. Dr. Montoya also serves as the co-chair of the HEAL Novel Medication Options for Opioid Use Disorder and Overdose team. Welcome, Dr. Montoya.
Thank you, Michelle. Thank you so much for inviting me to be the moderator of this session. I think this is a very important topic. As was presented earlier by Dr. Volkov, we don't have any medications for the treatment of opioid, for stimulant use disorders approved by the FDA. So we have some approved for treatment of opioid use disorders and overdose. But when patients have comorbid opioid use disorders and stimulant use disorders, we face a very important clinical challenge. So the purpose of this session is basically to address the current treatment approaches for patients with opioid use disorders and stimulant use disorders and the research opportunities. So we are going to try to cover the whole spectrum of therapeutic opportunities, including from new pharmacological approaches through immunotherapies or vaccines, psychosocial interventions, and digital therapeutics. So I'm going to start this session with the first presentation by Dr. Christian Heidbreder, who is going to be discussing the potential new pharmacotherapeutic interventions for opioid and stimulant use disorders. So Dr. Heidbreder is the Chief Scientific Officer of Indivior and is a global leader in the development of treatment for substance use disorders specifically. And he has a PhD degree from the University of Louvain in Belgium. He's an affiliate professor in the Department of Pharmacology and Toxicology at Virginia Commonwealth University School of Medicine, and a governance fellow at the National Association of Corporate Directors. He also serves as a member of the National Advisory Council of Drug Abuse, or NIDA, and a member of the National Institutes of Health, helping to end addiction long-term, or HEAL, multidisciplinary working group. Dr. Heidbreder has a long experience in the development of treatments, and I think we are all looking forward to your presentation, Dr. Heidbreder, so please take it away. And we have 5 minutes for questions. I don't see any questions on the chat, but I have a couple of questions, Christian, while people send questions. One is, you mentioned that the likelihood of approval for psychiatric medications is very low. But do we know the likelihood of approval for specifically medications to treat substance use disorders? And I think it's Steve Higgins is the next presentation, and Steve is a professor of psychology and psychiatry. And I think we need to move on to the next presentation. And it is really a great pleasure to introduce Sandy Comer. Sandy is a professor in the Department of Psychiatry at Columbia University, and Sandy has been working for many years also in the field of substance abuse, specifically in treatment and development and treatment for opioid use disorders. And now she is working on vaccines to treat opioid and stimulant use, but I think she's pioneering the development of a new vaccine to treat opioid use disorders. And we are very excited with her research at HEAL, and we look forward to hearing your presentation. Sandy, you take it away.
Okay, thank you, Ivan. Let's see, is the video on? No, not yet. Okay. So I would like to thank you, Yvonne, for inviting me to give this presentation here. And like Steve, it's really nice to see a lot of familiar names in the audience. So today I'll be talking to you about vaccines. I'll just briefly describe how they work. And I want to go into a little bit of detail about what the implications are for treatment when using vaccines. And then I'll end up with describing some of the challenges that we face when using vaccines as a treatment approach for substance use disorders. So just, very basically, the vaccines usually involve a series of injections that are given over several months in order to achieve maximal antibody production. And the general idea is that these antibodies will bind to the target drug and prevent it from getting into the brain. The three vaccines that we're working with nowadays, I have been collaborating for several years with Marco Pravatoni and formerly Paul Pentel at the University of Minnesota. So the three vaccines that we've been looking at are an oxycodone vaccine, a heroin vaccine, and more recently a fentanyl vaccine. And so the concept is that this hapten will target both oxycodone, but then also chemically similar structures like hydrocodone and oxymorphone. Heroin will target 6-acetylmorphine and morphine, and then fentanyl will target fentanyl itself and its analogs. So Dr. Kurt Rasmussen kindly shared this, or allowed me to share this slide with you. These are some of the medications that are in the NIDA development pipeline. And I've highlighted here the biologics that NIDA is pursuing. They include methamphetamine and cocaine vaccines, and also monoclonal antibodies. And several of these are currently in clinical phase testing. So the idea, especially with the opioid vaccines, is that we were, planning to develop a multivalent vaccine. So the two that we first were working with were the oxycodone and heroin vaccines. And again, because the vaccine targets a particular chemical structure, we thought, okay, we can combine the two vaccines into a bivalent vaccine. And then fentanyl came along, so we're like, okay, we'll add fentanyl to the pool. And now, as you've seen from previous presentations, there has been a really big rise in stimulant, related overdose deaths. So methamphetamine and cocaine are also commonly used in combination with opioids, as we've seen before. And actually, there's nothing to prevent us from thinking about a multivalent vaccine that includes multiple substances. So similar to the flu vaccine, and I just had a meeting recently with colleagues at the University of Montana who are developing adjuvants, for these vaccines that we're working with. And I asked them what the limiting step might be for, how many haptens we can include. And they said that, they've had their vaccines that have 30, 40 different types of haptens. So that's very exciting in my mind. So I want to show you some data that were collected in rats in Marco's lab to demonstrate sort of the concept that I was just describing. So on the top panel, I'm showing you increases in serum oxycodone levels in vaccinated rats compared to controls, and decreased brain levels of oxycodone. This is showing you a behavioral effect in vaccinated animals. So basically, the solid circles on the bottom are vaccinated rats, and they just don't develop oxycodone self-administration. The open symbols are the ones who received just the carrier protein. So these are data that we've seen before. This is it was updated, but The most common substances that are involved with overdose deaths include the synthetic fentanyl, opioids like fentanyl, and then cocaine and methamphetamine. So these are data that were collected and published recently in Marco's lab with their fentanyl vaccine. So same thing as with the oxycodone vaccine, serum levels of fentanyl increase, brain levels decrease in vaccinated animals. And importantly, what I'm showing you here is the dose effect curve for fentanyl in vaccinated and non-vaccinated animals. So the respiratory depression is reversed in vaccinated animals. And importantly, naloxone reversal of this respiratory depression is not affected in vaccinated animals. So now I'm going to shift gears a little bit and talk about how a vaccine might fit into the treatment options for substance use disorders. So one part of the progression is that it might prevent the development of substance use disorders. You know, you can imagine somebody giving a vaccine to somebody who's at high risk of developing a substance use disorder. And if they, you know, first encounter a substance, then maybe they won't progress to, you know, these later stages of the disorder. The vaccine can be used as treatment, you know, as a standalone medication. But also, this is really an important, you know, point here, is that it can be used in combination with existing medications like buprenorphine, methadone, or naltrexone, because, like I said, the vaccine targets the specific chemical structure of the drug that you're trying to treat, and so it doesn't interfere with any of the treatment medications because those have very different chemical structures. You know, vaccines typically last for several months. So one of the problems that we have with maintenance on these medications, even though they are quite effective in treating opioid use disorder, is that, you know, after 6-12 months, people relapse. And, you know, the relapse rate tends to be about 50%. So if there is a vaccine on board that has a longer duration of action, then, you know, there's a possibility that it could prevent, you know, full-on relapse to the abused substance. So what about illicit stimulant use? You know, one of the things that from the table that I showed you just now is that, you know, the overdose death rates related to stimulants is incredibly high. And in the case of a fentanyl vaccine, for example, you could imagine that, you know, so a lot of times fentanyl is cut into the cocaine or the methamphetamine. And so if you vaccinate a cocaine user who may not necessarily know that they're getting fentanyl in their drug supply, then, you know, you might be able to protect against overdose. So, you know, these are sort of the different areas: prevention, treatment as a standalone medication or as an adjunct, and a potential reduction in fatal overdoses. So we're currently conducting a NIDA-funded clinical trial of the oxycodone vaccine. We initially proposed to the FDA, you know, a study to examine the multivalent vaccine with oxycodone and heroin, but they came back and said very clearly that we had to, you know, study each component separately first. We chose to start with oxycodone because, you know, the overall numbers of people with who are physically dependent on oxycodone was higher. So our primary endpoint is safety. You know, we're using the usual endpoints there. And of course, immunogenicity. Again, similar, you know, usual endpoints. We're also examining preliminary efficacy in this study. So we are using the FDA preferred primary endpoint of mean peak ratings of drug liking. This is kind of what we're doing right now. It's a 2-phase inpatient period. There's about a 10-week initial inpatient phase, followed by an outpatient period, and then a second inpatient phase. They are receiving 4 doses of the vaccine. We have we're maintaining everybody on oral morphine, which is not expected to interfere with the vaccine response. And we're testing the effects of a range of doses of oxycodone and using heroin as the primary, as a positive control. So we have a baseline dose effect curve and then several post-vaccination dose effect curves that we're measuring. These are data from a previous study that we conducted to measure ratings of drug liking after administration of fentanyl, heroin, and oxycodone. So all of these drugs, of course, produce dose-related increases in liking. And what we're expecting to see is a decrease in ratings of liking. I mean, ideally, this is what we're hoping to see anyways, in oxycodones of liking, but then very little effect on heroin. So just to talk about one of the big challenges with vaccine use in historically, both the nicotine and cocaine vaccines made it to clinical testing, and both of them failed because there was too much inter-subject variability in the immune response. So they showed clinical proof of efficacy because about a third of the immunized participants generated a high antibody levels. But overall, there was not a positive signal. So Marco has been focusing on this particular problem and trying to figure out a way to solve it. And so what I'm showing you here are this is the reduction in oxycodone brain levels that I showed you before. These are data that were collected in mice. And in those animals that show high levels of oxycodone specific B cells, they showed the lowest brain levels of oxycodone. So, we're collecting B cell measures in our current trial to see whether or not this could be an approach to stratify, patients who may be more likely to respond to the vaccine before vaccination. So this would be an enriched population. We're also collecting data in the lab on, comparing B cell activity in naive. So these are opioid naive individuals and people with opioid use disorder. So what we're finding is that there's a significant difference in the frequency of opioid-specific B cells in these individuals. So these are not vaccinated people. There's no difference in the expression of TNF-alpha, which is it's an inflammatory protein cytokine. And there is a correlation, though, between TNF-alpha expression and opioid-specific B cells, but only for the opioid users. So we're thinking that maybe TNF-alpha might be a viable biomarker to predict vaccine clinical efficacy. We're measuring a bunch of other markers as well. Yep.
We have 1 minute. Oh.
Yep. I have less than 1 minute probably. So, vaccines seem to be working based on the preclinical studies. They show good immunogenicity and safety. They have demonstrated proof of concept and they show good selectivity and don't seem to interfere with existing medications for treating opioid use disorder. So far, it has been the oxycodone vaccine has been well tolerated in our clinical study. There are multiple implications for treatment, as I described earlier. Some of the potential challenges include, the vaccination regimen. We don't have a good handle yet on, what's the optimal regimen that we should use. We don't know so clearly what the duration of protection might be. And as I just described, the inter-individual variability in immunogenicity is something that we're paying very close attention to in our research. So I'd like to thank my lab and thank NIDA especially for making this research possible. And these are the folks from Marco's lab. So thank you.
They are all covered with face masks. Thank you so much, Sandy. This is great. There's a question, a couple of questions on the chat. One is from Nur Zaveri. Can the patient administered vaccine, can the patient administered vaccine administer a larger dose and overcome the vaccine effect?
Yes, they can. I mean, because the number of antibodies that are generated is finite, and similar to naltrexone, for example, you can overcome, and even with buprenorphine or methadone, if they use a high enough dose, they can overcome the blockade. But what we have seen in our naltrexone trials, for example, is that people are just not willing to spend a lot of money to try to overcome a blockade. And so we're hoping that that's the case with the vaccine as well.
Thank you. There's another question from Carol Hafner from NIDA. In your preclinical studies, are you using a single dose of oxycodone? And if so, would it be of value to test higher doses of oxycodone to see if it might influence the vaccine effect?
Yes, that's a good question. I only showed the single dose because I just thought it would be more simple to illustrate the point. But yeah, we've tested multiple doses of the agonist, and it is possible to override the blockade. So it all kind of boils down to what kind of how robust the antibody response is.
Thank you. I have a question, Sandy. So since this symposium is about polysubstance abuse, how about the possibility of developing an opioid and cocaine and opiate and methamphetamine vaccine based on what you experienced in Montana? It seems like it's pretty doable, isn't it?
Absolutely. I was so excited because I asked, we have these weekly big team meetings, and I typed it in the chat. I was just like, what is the limiting, what limits us in terms of the number of haptens that can be included in a single vaccine? And they said, well, there's nothing really. I mean, there are a couple of ways that you can add haptens, but they said that there are several existing vaccines that have up to 20 or 30 haptens. And so I typed in, okay, this is my wish list, and I had all of these that you were talking about. I said, okay, oxycodone, heroin, fentanyl, methamphetamine, cocaine, benzo.
A whole cocktail, even alcohol.
Yeah. That would be amazing.
Another question. So vaccines take a while to have the effect because you have to wait for the immune system to produce the antibodies. Mm-hmm. And if you have someone with an overdose while the vaccine is producing the effect, the person is not protected, basically. So what do you think about using monoclonal antibodies for stimulant overdose, or in general for overdose, for opioids and stimulants?
Yeah, I mean, I think that's a very good use of a monoclonal antibody, and that's a different sort of approach than the vaccine. There are some downsides of monoclonal antibodies compared to vaccines, but yeah, I think that would be great. And the thing that I think is particularly interesting and exciting about the vaccine rather than the the MAB approach is that you can use it in combination with something else. So while somebody is developing the antibodies to the vaccine, you can give naloxone and it should work. You can give methadone, you can give buprenorphine, and those are all protective. So, I don't think there's anything. It's kind of wide open right now in terms of how we exactly can use these vaccines.
Right. Well, thank you so much. There's another question, but unfortunately we have to move to the next presentation. We have enough time for Lisa Marsh to present. So thank you, Sandy. It's also a great pleasure for me to introduce Lisa Marsh. Lisa is the Andrew Wallace Professor and Director of the Center for Technology and Behavioral Health at the Gisel School of Medicine, Dartmouth College. So Lisa has been working for a long time in this area of using technologies to improve the treatment of substance use disorders. And the title of Lisa's presentation is Digital Therapeutics in the Treatment of Opioid and Stimulant Use Disorders. Thank you, Lisa. I don't see you on the, are you connected?
I should be connected. Can you see my video?
It's nice to see you.
Oh, nice to see you too. Thank you so much, Yvonne. Thanks for the introduction. And it's really a privilege to be part of this meeting on this very important topic of polysubstance use. And as part of our panel on treatment approaches for polysubstance use, as Yvonne said, I'm going to shift gears a little bit and talk about digital therapeutics as part of the treatment for opioid and stimulant use disorders. So in addition to my academic affiliation at Dartmouth College, I wanted to note that I have an affiliation with a few small businesses that are involved in developing and deploying various digital health tools. And I surely want to acknowledge our funding from NIDA for the work that I'll be presenting today, including for our center grant from NIDA. We have a center entirely focused on applying digital therapeutics to the treatment of substance use disorders. It's a research center, it's a national resource. It's called the Center for Technology and Behavioral Health. And for folks who might be interested in this space, we have an array of resources that we would welcome you to utilize. So digital technologies have really fundamentally transformed our society, mobile technology, cloud computing, data analytics, and they've changed our daily lives, how we do finance and retail and travel and education and social interactions, how we have scientific conferences. They've really fundamentally changed what we do in our daily lives. And there's a tremendous opportunity to leverage digital technologies in enhancing how we think about health and healthcare. So digital therapeutics is a term that refers to clinical grade software to prevent, treat, or manage a disease or disorder. So these are really tools, software that provides therapeutic support to help people learn new skills, to access tools that can help them in changing unhealthy behavior, that can help them manage a medical condition. They might be intensive behavioral treatments. They might help facilitate medical regimen adherence, but they're not simply general wellness promotion apps. Rather, they really are packaging and
Dr. Marsh, I'm sorry, you're muted.
Someone muted.
Am I muted now?
No, you're fine now.
Okay, but not sure what happened there. Thank you for telling me.
Yeah,
so
you were talking about it was not wellness.
Okay, so they aren't simply general wellness promotion apps, but rather they package an entire model of evidence-based care into a seamless digital delivery platform. So the idea is you take the core therapeutic processes in these interventions and you build it into the content and the functionality and the tools that you can access in the interactive software. So the promise of digital therapeutics, first, it can extend the reach and impact of clinicians. So these can be additional tools in the toolboxes of clinicians that they can offer to their patients that can be with them 24/7 and extend the reach and the impact of the work they might be doing with clinicians. So it's kind of like a therapist in your pocket. It's 24/7 accessible. And as I'll show you some examples, there's a very large and growing literature that shows that these tools can greatly enhance patients' clinical outcomes across lots of different patient populations, including people with substance use disorders. We know that these tools can deliver treatment with fidelity to best practices. And we know that virtually any population you can think of in the world, really, either it has access or is expected to get access to mobile devices. We do work not only in the US, but in some low and middle income countries. And we work in some communities that don't even have clean water or landline infrastructure, but they often have access to mobile devices. And so it's a tremendous opportunity to harness the widespread availability of these tools to provide personalized healthcare resources in new ways. So the idea is that we can have scalable, science-based behavioral health care anytime and anywhere. And as we all know, the utility of digital treatments, remote treatments, has become more timely and significant than ever during this past year, during the global pandemic crisis, when a lot of care has been shifting to remote models of care. So there is a large and growing literature on digital therapeutics for substance use disorders. And this slide summarizes sort of the big picture of that literature and shows that digital therapeutics, if they are developed well, and they really are developed in a way that has utility and engages your target audience, they can be highly useful and acceptable to diverse audiences. We have seen they can have a robust and replicable impact on many health behaviors and health outcomes, including substance use disorders. We've seen that digital treatments can produce outcomes that sometimes are as good as or better than clinician-delivered care. And some people sort of bristle in that and say, are you trying to replace clinicians with digital interventions? But as we all know, we don't have a sufficient substance use disorder treatment workforce to really meet the population level need at scale. And we know that so many people with substance use disorders are not engaging in their traditional models of care. So it's very important to know that these tools have active ingredients in the software that can really help produce important clinical outcomes. They can increase quality, reach, and personalization of care. They've been shown to be cost-effective in an array of contexts. And importantly, they don't always have to work the same way all the time. It doesn't have to be 12 sessions of some behavioral treatment or 8 sessions of a different one. They can be adaptive. We can maximally leverage technology to be responsive and adaptive to people's clinical trajectories and changing needs over time. So there are a number of clinically validated digital therapeutics for the treatment of substance use disorder, including those that have been shown to be effective in the treatment of both opioid use and stimulant use disorders, as well as other types of substance use disorders. And NIDA in particular has been a scientific leader within NIH and other funders in really pioneering innovation in this space and supporting the development of a wide array of tools that have strong empirical support. But in the interest of time, I'm just going to briefly mention one tool that we had the opportunity to first develop a couple of decades ago now, the first iteration of it, and it's been studied in a number of NIDA-funded trials. It was called, as a research version of it, the Therapeutic Education System. And it's an intensive behavioral treatment delivered entirely on a digital platform, modeled after what Steve Higgins spoke about earlier, the strongly empirically supported community reinforcement approach to substance use disorder treatment, which really teaches people skills and provides them tools embedded in the digital platform to understand and disrupt behaviors and cognitions that can contribute to self-defeating patterns of substance use. And it also includes a contingency management component where the entire contingency management, motivational incentives intervention part of the digital treatment is done in a seamless automated way within the technology platform. There are lots of sections to this. It's about 60 some different components. It's again based on this evidence-based model. I'm not going to talk about the tool in great detail. I use it mostly as an exemplar to show the kinds of effects you can see when you offer this in different types of implementation efforts as part of substance use disorder treatment, and the impact that we've seen it have on a wide array of polysubstance use. So the first study that I'll briefly describe was a randomized controlled trial that enrolled adults who were entering outpatient treatment with buprenorphine medication for opioid use disorder. Everyone received medication in the trial, and they were randomized to receive different behavioral treatments along with the medication. So if you were randomized to receive what's reflected in the blue column, you were randomly assigned to meet with a clinician in individual therapy sessions 3 times a week, and the clinician was trained to deliver this evidence-based community reinforcement approach plus contingency management. If you were randomly assigned to what's in the red bar here, you had a clinician, you checked in with them every other week, but the bulk of your intervention was done in an interactive way with the patient interacting with this digital treatment, the digital version of this evidence-based intervention. And if you were randomly assigned to the gray condition here, this is standard counseling reflective of what standard counseling for opioid use disorder treatment and outpatient treatment settings in the US. And so as one example of the many outcomes from this study, we see that even when you offload the bulk of this therapeutic intervention to a digital delivery platform, you can see comparable clinical outcomes outcomes to exclusively clinician-delivered version of this intervention, both of which produce better outcomes than standard treatment as measured by urine toxicology data looking at abstinence from opioids and cocaine. In a different study with adults entering methadone treatment, participants were either randomly assigned to treatment as usual, which is daily methadone medication and the kind of counseling you get in a methadone treatment setting, or a condition where the participants received methadone medication, but their clinician-patient time was cut in half, and the other half was replaced with a digital therapeutic. So instead of meeting with a clinician, let's say for 60 minutes, they'd meet with them for 30 minutes and then interact individually with the digital therapeutic for the other 30 minutes. When you cut in half patient-clinician contact time and replace that with this digital therapeutic, we had much greater weeks of opioid abstinence based on your toxicology data. And then just a couple of other examples in the interest of time. This is a study where we added a mobile treatment to existing treatment. Nothing was changed about the underlying treatment model. It's just a supplement. So you add a digital therapeutic access to treatment as usual. And when you offer that to individuals when they enter outpatient treatment for opioid use disorder, we see that they have greater retention in treatment. They were actually retained in treatment longer. And this is looking at the first 3 months of a treatment episode. And we also saw that translated into greater abstinence from opioids. The final study that I'll mention was a really pivotal trial funded by NIDA's National Drug Abuse Treatment Clinical Trials Network. It was a multi-site study conducted with partners around the US with lots of different polysubstance using populations, folks with stimulant use disorder, alcohol, cannabis, lots of polysubstance use. And what we saw is that when the digital therapeutic partially replaced part of outpatient counseling in these outpatient treatment settings, it increased clinical outcomes. So this is divided into patients up here who came into the trial already able to provide negative urine samples for their problematic substances. And if the digital treatment was offered to that sample, there's only a very slight advantage to those who were already negative for their problematic drugs when they started the trial and didn't get it. But the bigger, more robust effect is here among people who are actively using or showing positive urine toxicology data at the time they joined the study. When they get the digital treatment as part of outpatient treatment, we see much greater abstinence from substances versus if they're actively using when they join the study and they don't get the digital treatment as part of outpatient treatment. So we also saw that this enhanced retention in treatment when you get the digital tool versus when you don't. So just briefly, if you don't know this already, it may be of interest to know that right now in the US, one path to accessing digital therapeutics is that they can be prescribed. You can actually, physicians can prescribe software in the prevention, treatment, or management of a disease or disorder if the US FDA has given market authorization to a prescription digital therapeutic. So they're actually reviewing clinical trials data for the kind of rigor and safety and effectiveness to say that this, yes, indeed, can get a label for being effective as a prescription digital therapeutic. And the very first such prescription digital therapeutic in the US was approved in September 2017. It was based on the Clinical Trials Network study in a mobile version of that intervention called Reset. And then there was a second authorization called Reset-O specifically for the treatment of opioid use disorder in 2018. So this is, there has been an explosion of prescription digital therapeutics really in the last year during the COVID pandemic. And it's certainly something to watch because it's undoubtedly going to be a key part of the future of healthcare. So in closing, the data here show that digital treatments might offer accessible treatments for polysubstance use, really helping us think as we have this population level need of a strategy that can help us scale access to science-based treatment in a way that can transcend population and context. My last slide here is a link to our website. We have many resources at our center, but among those resources, we have a resource called a program review of clinically validated digital therapeutics for substance use disorders. So if folks have interest in this space, this is a place you can go and have a centralized resource of what's out there and what is the evidence behind those. So thanks so much for the opportunity to share this with you. Looking forward to your questions.
Oh, wow. Thank you, Lisa. This is great. Excellent presentation. We have a question from Jessica Madgidson. says approximately what % of patients in your methadone trials had access to a smartphone or other phone, or did you provide the technology as part of the research?
Yeah, thank you for the question. In that particular trial, we wanted to have a parallel groups design. So what we did there is actually we offered participants who were randomly assigned to the condition that included the digital therapeutic the opportunity to access that at the methadone treatment site. So they actually interacted with the digital therapeutic at that healthcare setting. It wasn't a mobile sort of version at that time. It was a web-based tool. And then that way we could control dose of exposure to that compared to the other intervention in the parallel groups design. And actually, I should mention, by the way, in that study, we had the opportunity to follow participants' outcomes for a full year. And that differential I showed, showing the advantage that people had in terms of their clinical outcomes when they got the digital therapeutic versus when they didn't, persisted for that entire 12-month period. But since then, many of these studies have now embraced mobile sort of access, and there's so much advantage to that, having it literally in your pocket anytime and anywhere. But for the particular trial in question, that's how we structured the design.
I have a question, Lisa, kind of building up on this question. In terms of equity and access to digital therapeutics, do you see that is more for certain groups than for others? What is the, and second question, what are the infrastructure requirements that you think we could have that should be in place to have more access to the digital therapeutics?
So it's such a great question. And there's a really active dialogue about the potential role that digital therapeutics can have in helping to tackle some equity issues and some health disparity issues, but yet many disparities still persist. So for example, if you think about sort of racial ethnic minorities, if you look in the US at least, it is the case that white Americans still have more computers and laptop computers that they use for online access, let's say in their homes. But if you look at mobile device access, we see that Black Americans, Latin Hispanic Americans have generally comparable access and utilization of mobile devices for healthcare related searches to their white counterparts. A big challenge though, is connectivity issues. And, you know, it's really, and that's in many communities, including in rural settings, and it persists, you know, not only in pockets of the US, but in many parts of the world. And so there are trends to increase connectivity, as we know, but one of the strategies that developers can use to help tackle that is that you can develop these tools such that they don't need to have active connectivity, but rather can function locally on devices and still provide rich therapeutic value, but not necessarily require real-time connectivity to the internet. There are many, many things to say about this topic. We could use a lot more time on it, but it's a very important question and a big area of research right now.
I don't see any other questions on the chat. I'm going to have another question just to, in terms of, again, polysubstance abuse, this approach is flexible enough that you can basically address any substance use disorder. So how do you assess the outcome when you have someone of this intervention, when you have someone with multiple substance use disorders?
Well, I think what's exciting to me is that, you know, not only, as you say, we can embed tools and functionality that can address multiple substance use disorders concurrently in the same individual. And you can look at that. You can look at their substance use outcomes. You can look at their functional outcomes. You can look at some of the key mediators that we know, the mechanisms by which these tools really exert those effects. But what's exciting to me is that although we're talking about using these tools in the treatment of substance use disorders, and there's really strong evidence supporting that the utility of these tools in that way, there is also very strong evidence that these digital tools, again, if they really reflect sort of the state of the science of intervention delivery, can really be useful in a transdiagnostic way and help with all kinds of health behaviors and health outcomes. And so we can really break down some of the siloed ways we think about what we treat and think about these tools that can flexibly be responsive to whatever combination of needs and preferences people present with. So that can include psychiatric comorbidities that can be addressed in a flexible way, embedded in this type of intervention. It can address other chronic disease conditions. It can affect pain management, and on and on. So, and we've seen that in some of our transdiagnostic work, that you can really think about the whole person and adaptive approaches to delivering these tools that can be responsive to that. And there's a lot of opportunity to still expand research in that space, but the data to date are really very promising.
Great, thank you. So I'd like to invite the other participants, the other speakers, to turn on their videos, and we will be answering questions. So please post your questions on the chat. I think while we wait for questions, it has been a fantastic session. Thank you so much for your presentation. I think we are dealing with a very big and challenging area of opioid use disorders and comorbid with other substance use disorders. The polysubstance abuse is a huge issue that we have heard for many, many years, but I think now that we see the numbers and the magnitude of this, and the expansion of what we used to call the opioid epidemic, and now it's like the polysubstance abuse epidemic, with the numbers of people that are dying from polysubstance abuse, I think is a call for action, and we need to do something. And I think what really excited me about this session is that there's a lot that has been done, but at the same time, there are lots of opportunities of things that can be done to address this issue of polysubstance abuse. So I wanted to highlight some of the things that I heard during this session. I think we heard from Christian about, in terms of medications development, all the opportunities that we have, the huge gaps that we have, but at the same time, the opportunities that we have in terms of not only like new targets, new medications, and the use of technology like machine learning to identify potential effective treatments that we haven't done until now. So it is great. And I
just had a thought. I mean, so I think all of our presentations, Lisa, yours, mine, Steve, and mine, discussed ways of, directly addressing polysubstance use. But I think Christian raised a really good point that the endpoints that the FDA requires are so stringent, and they differ according to drug class. So it's different for alcohol versus cocaine versus opioid. So this is going to require a lot of discussion with the FDA.
And that's where I was going to. That for us also as a funding agency, as NIDA, as a funding agency, and we're trying to support the development of therapeutics to treat substance use disorders. We're trying to accommodate to the FDA requirements, but at the same time, it's like we maintain a balance of making sure that the medications that and the treatments in general that we are supporting the development get through the FDA, but at the same time, we see the need in the field of treating the real world of polysubstance abuse. So I think that is it's a very difficult balance, and it's so when like an excellent research proposal that is looking at treatment for comorbid opioid use disorders and stimulant use disorders, but we don't have any medication approved for the stimulant use disorders. How do we know if that is going to work for opioid use disorders or not? So it's really very difficult. One thing also just to reflect a little bit on the presentations that I heard, and also from Steve's presentation, is the excellent effects that we see with contingency management in the three endpoints that he presented, but there may be other endpoints. And one thing that I was thinking was the use of contingency management in the development of other therapeutics, like the development of medications or vaccines, or even for digital therapeutics as platforms they have been used, but maybe they need to be more systematically used in order to be able to see the effect of the medication without overwhelming the effect of the medication, because sometimes behavioral therapies can overwhelm the effect of the medication and we don't see the effect. So that's another balance when we try to use very effective behavioral therapies that with a medication that may not have such a strong effect. So what do you think, Steve, about like what?
Yeah. Oh, I agree completely. And, you know, science involves humans. And sometimes we don't always act in the most rational way. So I always felt at times back during the cocaine epidemic that there was kind of competition between the behavioral branch and the medications development branch, when I've always felt that we should be working in concert. And for the reasons
we are all merged now. We are all together now.
Oh, wonderful. So I think it's a great opportunity. I just was so impressed by the other presentations in this panel. And I feel optimistic that now is the time to do things that maybe we missed opportunities to do in the past. So I love the point you just made, Yvonne, and maybe you can lead that effort.
Yeah.
Support it.
Thank you. I'm going to give an opportunity to those who write on the chat, because I can't talk the rest of the afternoon. So one comment comes saying, as we shift to treatment specific to polysubstance abuse, how do speakers suggest we begin to think about the traditional primary outcome in treatment interventions? Typically, we examine changes in one substance use over the intervention period, but this needs to shift to perhaps substance of preference or some other measure. Any comments from the panelists?
Well, I think
again, if I may,
please,
Ivan, I think that this is going to require a lot of discussions with regulatory agencies. And we are not there yet, but in a way, I think that the epidemiology is now driving this kind of discussion, because we are in an emergency situation with clear polysubstance abuse. So I would even argue that it's now or never that we need to engage agencies in these discussions. The other thing that is quite interesting, and I even saw it in the introduction this morning, is that we are talking about the development of anti-craving medications. And it's all good theoretically, but unfortunately, craving is not recognized as an endpoint in clinical trials. And the reason why I'm saying that is that we probably have a unique opportunity to really do significant research around craving, irrespective of drugs of abuse, and demonstrate with hard data the role of craving in drug-seeking, drug-taking behaviors, and convincing with data-driven proposals, of course, that craving is a key component that should actually be included potentially as clinical endpoints. So I think a lot of things can be done there, but it must be data-driven. And I think there is a wonderful opportunity right now, especially with all the other presentations that we have seen today, to really drive that movement at a time polysubstance abuse is becoming really, really problematic, especially from a treatment perspective.
Steve, you were going to comment?
Yeah, one of the earlier presenters showed data that most people who present substance use disorder treatment identify a particular substance that brings them in to seek treatment. And then you assess broadly, because multi-drug use is the rule rather than the exception. But I think they will self-identify almost always as a particular drug or class of drugs that brings them in for treatment. So,
yeah. One comment about what Christian just mentioned. I think, Christian, one of the perhaps opportunities is also to look at data from clinical trials about looking at craving, not only craving, but other outcome measures, and try to validate those outcome measures to present to the FDA and see if the FDA will be willing to accept them for med development.
I totally agree. As part of that, I think that patient-centered outcomes and in a way giving the voice of patients during pivotal clinical trials is going to be increasingly important. So rather than simply looking at the effect of a medication or a combination of a medication and contingency management or digital therapeutics, is to demonstrate that overall you also hopefully see an improvement in health-related quality of life endpoints, so that we have a much more holistic view as to the benefit of treatment in multimodal fashion, if you wish. So again, a great opportunity there to do additional research and really engage the regulatory agencies with data and demonstrate that this is definitely the way forward.
Thank you. There is a comment or a question on the chat from Sonia Martin. A question for Dr. Marsh and Dr. Higgins. In your studies, did you have a way to keep track of whether participants were concurrently involved in other abstinence-based programs of support? For example, mutual aids group.
We usually track that sort of information in our studies, yeah, and we certainly had no prohibitions against that. These were usually parallel group designs, like Lisa was mentioning, so we would track that in both the intervention and the control treatments.
So we too have tracked that often. We've never really systematically looked at, whether engagement in those additional programs along with the therapeutic interventions we're offering have any sort of systematic effect on outcomes. I'm not sure if that's what the question is getting at. But one thing that might be of interest to Sonia is we've started to get some really promising data from one of the lines of research we're doing in digital therapeutics, where we're sort of going social with digital therapeutics. And the idea is that, digital therapeutics offer a lot of tools and functionality now often to one person, right? And it's a therapeutic individual targeted at the person seeking to change some behavior. And going social with a digital therapeutic doesn't mean necessarily, adding a social support group to it, but rather actually having an extended network, a social network of your choosing that can actually use the tools with you in real time. So you can share your progress toward personalized treatment goals and successes and milestones achieved. They can actually use contingency management to give you reinforcers in the context of the digital platform. There are other sort of tools that can engage in problem-solving therapy exercises with you. So they're actually using the tools with you so that you have a support network wrapped around your use of the tool. And we've gotten from some early stage data, some really promising outcomes from that, suggesting it might help with people staying engaged and retaining people in treatment longer. So that might be a line of research of interest. Glad to tell you more about it if you want to follow up.
I just want to quickly compliment you that that's the digital translation of community reinforcement, right?
Exactly. Yeah, thanks, Steve.
One question, Lisa, the use of digital therapeutics in RCTs for medications or for other types of interventions, what's the experience of using digital therapeutics in a form?
You cut out a little at the end there, Yvonne. What's the experience of using, can you say it again?
Digital therapeutics as a platform for clinical trials, to use like a basis for clinical trials of other interventions, not necessarily the RCT for the digital therapeutic, but the RCT for something else.
Right. Yes. Well, one example of that is that there are a number of people who use digital therapeutics as a way to standardize a baseline behavioral treatment when they're trying to test the effectiveness or efficacy of some novel pharmacotherapy, for example, right? So that you don't have lots of variability in the behavioral treatment that's being offered concurrent with that across sites. But this is a way to ensure more standardization of that. I was thinking, Sandy, when you were talking, that I thought your talk was fabulous, by the way, and it's such exciting work you're doing. But I was thinking, you know, there might be some really interesting opportunities to think about these digital treatments concurrent with sort of vaccine use, including trying to promote adherence, right? If you have to take it every 6 months or at some interval like that, and also providing additional sort of resources on top of the vaccines, just like we've seen some of the synergistic effects with pharmacotherapies and behavioral treatments. It might be really intriguing to look at that in the vaccine development space as well.
Yeah.
I've given you a call when we move into the phase 2 studies.
Okay, please do. That sounds great.
Yeah, this is great. I don't see any other questions on the chat. Oh, Nora has a comment.
Yeah, no, I've been trying to get a comment. No, I think it is very impressive, and I was fascinated, while at the same time, I mean, I guess made aware about the complexities of bringing treatments that into the clinic. And Christian pointed at 10, 12 years effect, and yet people are dying. I mean, so my question is, do we really have that luxury of 12 years? That's item number one. And particularly now that we have seen how we can advance very rapidly treatments with COVID pandemic, that there are ways of accelerating discovery, and it just behooves me that now we should learn from it. That's one. And the other issue that bothers me constantly is we can have the most extraordinary treatment developments, and if they are not reimbursed, patients are not benefiting them. And I'm thinking about the extended release formulations of buprenorphine or even naltrexone, which actually are likely to be beneficial for preventing overdoses with fentanyl. And yet very few patients are being prescribed this medication. So how do we, I mean, what do we do different? So to accelerate on the number one, the development and the ability to get these products. And the second one, how do we keep our eye to ensure that advances in science actually are made accessible to everyone, just like we're being making accessible vaccines to everyone? How do we do that? What do we need? I would welcome any thoughts that you have, because I think that if we don't ask ourselves those questions and sort of stay on this 10, 12 years trajectory, how many patients are going to die before we have something approved by the FDA?
Well, Nora, I'll comment on that, because the agency that's on my mind is CMS, and allowing Medicaid funds to support contingency management. And I don't have a solution, but I am completely on board with your suggestion that we have to do more, and that people are dying. In this instance, with the psychomotor stimulants resurgence, and the one treatment that we have unequivocal evidence we can't offer because we can't get reimbursement for it, or we can't get use Medicaid funds. So I think we have to be the advocates more so than we're used to being as scientists, I think, because for one thing, our disorder is overrepresented in disadvantaged populations. So they don't have their natural advocates like you do, say, with HIV medication and the gay men, where there was not social, it was not overrepresented in any kind of disadvantaged population, and they had very, very strong advocacy, and it was effective. So I would love to hear suggestions on how we could do more along those lines, because I think it's absolutely needed.
I would recommend too that we consider having meetings like this that include a broader array of stakeholders, including policymakers and payers. We're part of the NIDA Clinical Trials Network, and our node of the CTN has a policy payer advisory board. It's just phenomenal to hear the perspectives of payers and policymakers and what they're looking for, and the data they're looking for, and the science that they're looking for. And so I think having an opportunity for more active dialogue about what we could do together and what are the timely and significant opportunities would be a tremendous opportunity for us.
One of the other things, Nora, that I was thinking as you were asking your question was, I mean, with the COVID vaccines, one of the big things that, so we'll learn from that experience, I think, of developing, the vaccines quickly, but we should have discussions with the FDA about emergency use authorization for some of these medications that look promising, and whether that would be something that they would find feasible.
I agree. And I think that that's why I'm posing the question, because I think that we need to be bolder. I mean, we've seen it can be done in the past, and yet, I mean, because addictions have been stigmatized and they are placed at much higher obstacles than any other treatment, including how much you are willing to pay to take care of a patient. And yet the costs are what we're observing, a significant increase in mortality.
Mhm.
And again, I think that the numbers that we see now, I mean, are frightening, but they really are just one component of mortality that is not being counted in many other ways.
Mhm.
So I guess that it is, I like very much the idea of when we organize meetings like this one, bring a diverse cohort of other agencies. And two, I mean, learn, I guess, what we've been discussing is in terms of bringing forward families and patient groups that can also put a strong advocacy to try to change this landscape that is going so slowly.
I totally agree. And if I may, again, as I said before, I think we need to have a very serious discussion about clinical endpoints and how we are going to allow significantly more flexibility. And as I said before, a more holistic view of what recovery is actually, how recovery is actually defined, rather than strictly the use per se. So I think there is a huge opportunity to engage regulatory agencies in that debate in light of what the epidemiology is actually telling us right now.
Thanks.
Well, on that note, I think we have to stop, unfortunately. I guess 3:55, the time is up. So I just want to thank again the panelists for this great session, and very thought-provoking. I think we have big challenges ahead of us, and I think the work with the FDA is critical, and our division is trying to help on that, but I think it's something that needs to involve lots of stakeholders, including families, patient advocacy groups, like the example of AIDS, and push and keep pushing, and also policy makers and others to keep pushing the FDA. Okay, well, thank you so much. And I think we're going to stop now. And Michelle, do you want to have any announcement, or you?
Yes, thank you, Yvonne. So we have just a couple of minutes for a quick break. We'll start at 4 p.m. to honor the time slots of the speakers. Thank you all for a wonderful session, and we'll start again at 4 o'clock, 2 minutes.